Mr. Michael Schomer, please go ahead.
Thank you for joining us for the COVID-19 media call for October 23rd. We'll start today's call with comments from Health Commissioner Jan Malcolm and State Epidemiologist Dr. Ruth Linfield. Following that, we'll hear from Dr. Ty Mendenhall, who is the lead of the University of Minnesota Medical Reserve Corps Mental Health Strike Team and a team leader on the Minnesota Behavioral Health Medical Reserve Corps. We'll then open up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thank you, Mike, and good afternoon, everyone. An additional 500,000 cases of COVID-19 and an additional 5,885 deaths were reported around the world this morning. That brings the total now to above 41.7 million cases and over 1.13 million deaths around the globe. The United States added 72,000 more cases and 839 more deaths as of this morning, bringing us now in this country to over 8.4 million cases and over 223,000 deaths. Here in Minnesota, we added 1,721 new cases yesterday on a testing volume of 26,742 tests. So we are now at a total of just under 130,000 laboratory reported cases since the pandemic began. Sadly, Minnesota added another 13 deaths yesterday, bringing our total now to 2,314 of our family members, friends, neighbors, and coworkers who have died of a preventable disease here in Minnesota. 2 of these deaths occurred in residents of congregate care facilities. The 13 deaths were spread across 11 counties and a wide range of ages, including 2 persons in their 50s and 1 in their 40s. All 3 of these younger individuals did have previously known underlying conditions. Since the pandemic began, there have been a total of 9,338 patients in the hospital. 2,510 people have required intensive care. The current number of hospitalizations is 565, including 160 in intensive care units. This is not as high as we saw in May, but we are approaching the same level of hospitalizations as we saw earlier in the pandemic. The 7-day rolling average test positivity rate as of October 14th has increased further to 6.4%. The gap between the weekly growth in cases, which is now 9.5% for the last 7-day period, and the growth in testing, which is 6.9% over that same week, an increase of 6.9% over that same week, has continued to grow. So that gap is between case growth and testing growth has increased a bit, partly admittedly because we had some very, very large testing days in the prior week. But what this indicates to us, both the increase in test positivity rate and that gap between case growth and testing growth, just does indicate that the case growth is due to very high levels of transmission of the virus around the state. There is more disease out there, and not just because we're doing more testing. Yesterday, we announced the pilot of the new COVID-19 Test at Home saliva program. Minnesotans in 23 counties, as well as the Red Lake Nation, are helping us pilot test process to order a saliva test online to perform in their own home. This is a very important development in our saliva testing program and in our overall testing strategy. The testing strategy is really about having a range of options for people seeking out testing so that tests can be done quickly and results returned quickly so that people can take the appropriate actions, not only to get the care they may need, but to take preventive actions to avoid further spread. Having more testing options
Operator, did we lose the commissioner's line?
I believe so, sir.
Okay, I think we'll have to have her dial back in. I apologize to everyone for that. But Dr. Mendenhall, perhaps if we could start with your comments, that would be something we could do until she's back on with us.
Sure, I'd be happy to jump in. My understanding of your invitation today is that we're alongside the physical health and illness that is obviously on everybody's minds with COVID. We're also trying to include and attend to attention regarding mental health, and certainly in general with COVID, but then also mental health as we approach the winter months. This can be a tougher thing anyway. I mean, even without COVID, I mean, a lot of people struggle with our Minnesota winters, cold, less light, etc. But I think as we go into the winter months in our current context, there's going to be a lot more fear because just about any single symptom that is pretty normal for winter, like a scratchy throat, is going to be connected to these worries on, do I have COVID? How many people have I infected? Am I going to die? And those types of fears are new. We didn't used to think that last winter when we got a tickle in our throat. We're losing new routines potentially that we just got done gaining, that we're outside more, that we're exercising more at home, and now we can't do that. And there's a lot of stress around upcoming holidays. Do I, for the very first time, not host Thanksgiving? How am I going to have that conversation with my parents when I tell them I don't want to come see them at Christmas time? And, all of this is applicable to all of us. And I think that as we attend to this for all of us, that is important. And along the way, I think that we need to attend to it more, even to people like healthcare providers, certainly mental health care providers, teachers, instructional coaches, administrators. I mean, these folks whose job really requires a one-way direction of support and intimacy, and for a variety of different reasons are already a higher risk group for burnout and compassion fatigue. And so, I honestly could talk all day about these types of things, but I think that my three main walkaway points would be recognizing and giving yourself grace around mental health, mental illness, struggles like this as stuff that's real. It's important. What it means is that you're human. I think that if you can roll with or resist some of the stigmas that a lot of us have grown up with or seen or experienced, that if we're having trouble above the neck because we're depressed or we're fearful or we're anxious, that it's somehow a character flaw, it's not. Your brain is just as physical as any other part of your body. And I think that if we can address and think about and honor the humanness of mental health, that a lot of our struggles are going to go better, broadly defined. And I think that leads to the second main point that I would hope that people can hear, and that is that if you are hurting, seek help. Reach out. I mean, there's a variety of different professional resources that are out there, of course. I mean, the MDH website has a number of things. You can go to therapistlocator.com. I know that Psychology Today, I think it's .com/US/therapists has a number of different resources. You can connect with the phone number on the back of your insurance card. Those professional resources are out there, but what I would encourage you to also do, or folks to also do, is to look at non-professional resources. A lot of times the peer support that we can get from, weekly family Zoom calls or weekly friends from high school Zoom calls, faith communities participating in that can go a long way. And I don't think that seeking help always needs to be coming from a doctor. I think it can come from anywhere. And if we think about it that way, a lot of times we're going to have more options in terms of what we can access. And then I think the third point that I would conclude with is to remind ourselves that there is no one-size-fits-all solution. There's no panacea here. I mean, for as long as there's been humans, we've been looking for, a single answer, the book du jour or the charismatic speaker du jour that can fix everything. But we're a lot more complex than that. And as we think about our bio, psychosocial, even spiritual layers or worlds that we inhabit, I would encourage folks to personalize what they need to them. If it's biological and it's sleep hygiene, diet, exercise, even meds or seeing a doctor, then maybe that's what works. And if it's psychological, like the therapist, meditation, self-care apps, books, resources like that, then roll with that. If it's social, like, quality time with your spouse, your kids, because you haven't been doing that, and doing that without your cell phones in the way, having carpet picnics in the living room instead of putting off stuff like this, games, well with that. And even with spiritual, a lot of people don't want to touch that because it's very personal and everybody sees and experiences their faith differently. But sometimes that's where people need to go. And I think that if we can personalize what we need for us and not be looking for, that one single silver bullet, then a lot of times we're going to be better able to navigate where we're hurting. So, and again, I think a lot more details, but those would be my main points that I would want to raise. And I'll either, with that, transfer it to Dr. Linfield, or we can pick back up where we had some technical problems before.
Yes, thank you, Dr. Mendenhall. I think we've got Commissioner Malcolm back, so we can turn back to her.
Yeah, thank you. My apologies, everyone. My line dropped somehow. Thank you, Dr. Mendenhall, for that really helpful discussion. I'd like to kind of pick up on a couple of his points and then just briefly come back to the saliva testing pilot. As I heard Dr. Mendenhall say, this is just going to be an extra level of importance around mental health and resilience and support, and as we expect some really unprecedented additional pressures on top of what is always an under-attended to dimension of our health, that all critical mental health and well-being that is just as important and just as real as the other physical ailments that we are often, as the doctor said, more comfortable talking about and dealing with. I just want to mention a couple of resources that can be found on our MDH website. One to mention specifically is a specific COVID CARES stress phone support service. Any Minnesotan experiencing stress can call the following number, 833-HERE4MN, so spelled out HERE, the number 4MN. That is 833-437-3466. And this is for free telephone support from 9 in the morning to 9 at night, every day of the week. This service is a collaboration with volunteers from the Minnesota Psychiatric Society, the Minnesota Psychological Association, the Minnesota Black Psychologists, and Mental Health Minnesota. The free service is also accessible at fasttrackermn.org, where searchers can also find psychiatric and mental health services and real-time substance use disorder treatment program openings. We also have information online for other resources, including the American Red Cross Virtual Family Assistance Center, the Federal Disaster Distress Helpline, the National Suicide Prevention Lifeline, and Minnesota Mobile Mental Health Crisis Call Line. And of course, these professional resources are only part of the support system we need to have in place. And I appreciate Dr. Mendenhall's coverage of some of the ways to think about this and the ways to approach this upcoming season. And so thank you again, Dr. Mendenhall, for joining us. We will, on a future call, come back to the topics around safe holiday planning and kind of revisit some of those resources from the CDC website and our own. I just want to circle back for a brief moment to the home saliva testing pilot that I mentioned. I just want to make it clear that that pilot program in 23 communities plus the Red Lake Nation is about making sure that we gather more information about how the program will work, not just in our larger cities, but in our smaller cities and more remote rural areas of the state as well. It's going to help us troubleshoot any issues or make necessary adjustments before we roll this program out to all Minnesotans statewide, which we hope will happen in November. With that, I will turn it to Dr. Linfield for an update on some clinical issues. So take it away, Ruth.
Thank you very much, Commissioner. We have talked in the past about the multi-system inflammatory syndrome, or MISC, and have said that we would provide monthly updates. And so I'm going to provide that update today. To date, we have had 28 children that have been confirmed in Minnesota as having MIS-C, with 5 cases being reported in September and 2 being confirmed in October to date. This is a severe syndrome in children that is thought to be associated with SARS-CoV-2, and 88% of our cases had either a positive PCR or antibody to SARS-CoV-2, and the other cases had been exposed to a confirmed case. Approximately 2/3 of these children were previously healthy. All were hospitalized, and 57%, so more than half, did require intensive care. All of these children presented with fever. 86% had gastrointestinal symptoms, and more than 70% had evidence of heart involvement, including abnormalities on echocardiogram in about half. Fortunately, all of these children are now home, and we have not had any deaths. The age range among Minnesota cases has been 6 months to 16 years, with an average age of 5.5. Nationally to date, there have been 1,097 reported cases and 20 deaths, and the average age nationally is a little higher at 8 years. Both in Minnesota as well as nationally, Black children as well as children who are Hispanic have been disproportionately affected, with approximately 75% of cases being children in these groups. To put, though, the Minnesota numbers in perspective, we have had 28 cases of MIS-C out of more than 20,000 cases of identified SARS-CoV-2 infection among those aged 0 to 19. What I also want to bring to your attention today is that CDC published a report on MIS in adults, so MISA. This was on October 9th. It includes data from published case series as well as cases reported to CDC, and they have identified 27 cases in adults and 2 deaths. These cases have had multi-organ involvement that has been extrapulmonary for the most part. Sometimes there has been mild pulmonary involvement, but they have had cardiovascular, gastrointestinal, dermatologic, and neurological symptoms without severe respiratory illness. They have also had positive SARS-CoV-2 tests. Sometimes it has been antibody. Many were PCR positive. And frequently, these symptoms came on 2 to 5 weeks after their acute infection. And so we want people and clinicians to recognize this is also extremely rare, but when symptoms occur, certainly individuals should be evaluated because there is a high rate of critical illness in these individuals. Thank you. I will now pass it back to Mike Schilmer.
Thank you, Dr. Linfield. Operator, we are ready to take questions.
Certainly, sir. At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. Again, that's star 1. We'll pause for just a moment to compile the Q&A roster. We do have a question from the line of Ms. Catherine Richard. Ma'am, your line is now open.
Hi, I have a question about testing today. It's my understanding that there is some agreement you have with North Dakota that allows folks in the Moorhead area, or sorry, the Fargo area, to get tested at the saliva clinic in Moorhead. Can you say more about that? And also, I'm wondering if you could say anything more about whether folks from surrounding states like Iowa or Wisconsin can come to the free pop-up MDH PCR clinics that you guys are doing.
This is Commissioner Malcolm. Thanks for that. And we may have to confirm a few details for you offline, sure, Catherine, but in general, these testing sites are intended for Minnesota residents, and so we do ask for that as a priority. However, sometimes we have visitors in the state who've been who believe that they have been exposed. So on a case-by-case basis, certainly some folks who are not Minnesotans are getting tested. The exception for the Moorhead site, as you point out, we have been talking with our colleagues in North Dakota, and we are going to make some testing available for North Dakota residents in the Fargo area to come to that Moorhead site, because the reverse has also happened. And over the last several months, North Dakota has tested a significant number of Minnesotans with their testing program. So out of a spirit of reciprocity, we did, with some parameters, we did agree that that site would be open to North Dakotans.
And just to follow up, this is sort of a resource question as well. I mean, we've been saying, you guys have been saying, on every call that we're seeing hospitalizations go up. Again, I feel like I have to ask this every time. Are you seeing any, serious red flags when it comes to hospital capacity, labor shortages, PPE shortages as those hospitalizations go up?
If part of your question is, how many of those hospitalizations are non-Minnesotans who are getting care in the Minnesota hospitals, we could get you that data offline. Certainly, we know, particularly in border communities, but for other reasons as well, we do some Minnesota hospital capacity is in use from folks from other states. And as it is a tight situation, as we've been reporting, not so much that the hospitals are full of COVID cases, that's still a small percentage of total admissions, but that they're very full. And so there's very, very little slack in the system, so to speak, as COVID cases begin to grow again or have been growing again. So, what we are really hoping to avoid, of course, is hospital shortages for any critical care, not just COVID care. We've talked a lot about the systems that are in place. We could certainly do more in depth on at another time on that, how it is that the capacity is being tracked and really managed so that hospitals get assistance when they need it. In moving capacity around the region or around the state to make room for the most critical cases.
Okay, thank you.
Our next question comes from the line of Mr. Glenn Howett. Sir, your line is now open.
Thank you. On Wednesday, the CDC changed its exposure guidelines from 15 minutes close contact to an infected individual to 15 minutes over the course of a 24-hour period. So I assume you're going to change your guidance as you usually do when CDC changes theirs. But I wanted to get a sense from you of how this might impact healthcare workers and schools, as it appears that more people will be considered exposed with this new definition.
Commissioner, would you like me to comment on that?
Oh, I'm sorry, Ruth. I was on Mute, just chattering away here. Yeah, I would. I'd love to pull you in on this one, but just to mention at the outset that operationally, we've actually been considering that close exposure time frame in a more cumulative way. So it's not actually a dramatic change in how will be approaching case investigations and contact tracing, but can certainly try to quantify in response to your question about what implications that might have in the future. But Ruth, let me bring you in here.
No, I was going to agree with that. Thank you. That is how we have been operationally doing it. We recognize that there are lots of people who are involved in assessing exposures, and not all of them have been doing it that way, and it will involve people adapting. But, I think everybody needs to recognize it's not a perfect science. Whether somebody is exposed enough to acquire the virus depends on lots of things. It depends on the proximity. It depends on how much virus is being expelled by the infected person. In other words, how contagious they are. It depends a bit on how much the person is taking in and some specific host characteristics. And so as we learn more, we, as a public health community, refine our guidance over time, and we will continue to do that.
Thank you. And since this does involve contact tracing, I wanted to catch up on that. The last time I looked at this, MDH was planning to hire two firms, one that would hire staff and the other who would manage the whole process. Where are you at with contact tracing right now?
We'll have to get you probably the exact staffing numbers, but we've staffed up significantly in this function in order to be able to keep pace with the growth of cases, and that's been both through hiring of new staff, which we have contracted with a staffing agency to help us with that, and a significant amount of redeployment of MDH staff from other areas outside of the core EPI team that has been doing this all along. Folks who are trained on particularly the contact tracing part of the exercise. So we have literally hundreds of MDH staff who've been kind of surged, if you will, to support this function too. But we have in addition hired a number of additional staff through the staffing agency. I'm sorry, Glenn, I don't have specific details at my fingertips about how many, but certainly can get that for you.
Thank you. I'll contact your media people. Thank you.
Our next question comes from the line of Mr. Paul Scott. Sir, your line is now open.
Hi, thanks so much. As case numbers rise, it's only normal that healthcare workers are going to be exposed. I'm wondering if you're tracking the effect on diminishing hospital bed capacity in the state, not from patients taking up beds, but from quarantining of staff needed to make beds functional. Do we know if more nurses are being sidelined by exposure and the need to quarantine? I've heard that's happening.
We do. This is Commissioner Malcolm, and Ruth, I'd invite you to chime in here too. Chris probably could give you specific case numbers. Perhaps Ruth has access to that as well. But yes, it is certainly true that healthcare worker infections from community spread have continued to increase. We don't have the same kind of data reporting mechanism in place right now to know how precisely that is affecting staffed bed capacity in the hospitals. But we are talking with our health system partners about just how to, make sure that information is flowing, that they, that they are always looking kind of at that literally on a day-to-day basis. I think we heard that from the CEO of Hennepin Healthcare when she joined us about a week ago, that indeed that that does affect bed capacity on a day-to-day basis. I can't give you, a total picture of what that looks like statewide, but we are, suffice it to say, really focused on this as an issue, and we're talking with our health system partners about how we can get the best line of sight to where there might be pressure points building.
Thank you.
For anyone who would like to ask a question, please press star 1. As of the moment, we don't have anyone on queue.
All right. Well, thank you for the time this afternoon. I know that some may have follow-up questions, and we'd be happy to work with you from the communications office this afternoon. Have a good day, and we'll be back with you again on Monday.
This has been a WDIO News Special Report.